and to use the chat box to put your questions into. So far, we're up to 47 participants, and we'll try to. This could become a somewhat chaotic process. We're experimenting here a little bit with how this works, so please bear with us. We have a somewhat mixed audience with lots of different people with different experiences and knowledge from different parts of the world. Some of the discussion may not be directly relevant to your situation. Just be patient as we find the best, most open format to accommodate people's needs while creating a space that brings all of us together. Please note that this is a global audience, so we'll not be able to answer questions that are specific to particular country situations. This is the first time we're doing it, and we want to be as transparent and open as possible, so please bear with us. We're going to start with everyone being able to speak, but if this becomes unmanageable, we'll mute participants. So raise your hand or chat if you have a topic you'd like to discuss. We have a series of questions we're going to put up on the screen momentarily to frame some of the discussion. I want to thank our partners, the International Association for Hospice and Palliative Care, International Children's Palliative Care Network, PALCHASE, Palliative Care Voices, and Extra Special Kids Irish Support Group. The questions that we thought we would begin with, and again, I'd like to ask people to mute their mics if they're not speaking. I will put up here momentarily. Bear with me. We're still getting participants. We're up to 56. Okay, so the first question that we wanted to address, and I want to also mention that this is part of a series of webinars that we're intending to provide for the palliative care community in partnership with our other international organizations. And we will use some of what we learned today from you all to help structure future webinars. But we also have some ideas about particular topics that we think that you will be interested in hearing about. So the first question was, what are your expectations of this time? What would you find useful to discuss? And we'll come back to these questions as we get further in. Please mute your microphones if you're not speaking. So, what's the most important thing to you now as affected people or palliative care professionals? What are your biggest challenges? Oh, I want to mention that we do have several experts on the line. We have Elizabeth Bancroft, who's heading up the World Health Organization work on personal protective equipment. We have Beth Matfield from UN Office of Drugs and Crime, UNODC. We have a number of key palliative care leaders, including Dr. Raj Gopal from India. I think Zippy is joining us, Dr. Zippy Ali from Kenya, and Joan Marsden, who's leading up humanitarian response, Libby Salmo, and others, including Julia Downing from the International Children's Palliative Care Network. So those will be resource people for us on this call, including Lucy Watts, who is one of our spokespersons, who is an affected person herself getting palliative care. And I see Mar Lang on the line. So you can put your question into the chat. Zippy has said too much confusing information on social media, which is frightening patients and caregivers. Any specific guidelines for palliative care providers? That's a great question. One we weren't anticipating. We've tried very hard to provide a signposting at our website, WHPCA.org, with the section on COVID-19. We're being quite careful to ensure that the information that's posted there is accurate, that there is no confusing or frightening information that is inaccurate. As I know there's a lot of it on social media. Frankly, my advice is ignore it and only look to guidance from reputable sources like the World Health Organization. John Marston. What you're asking about what's been successful and what is not working, I guess. That is also one of the questions that we wanted to address. Let me bring back up the list of questions. Please mute your microphones if you're not speaking. So the other questions are, how are we addressing the main challenges in your setting? How are we addressing the shortage of personal protective equipment in households and healthcare settings? What resources and information do you need, and what are you finding useful? How are you looking after yourself? And how would you like to hear? What would you like to hear, and who would you like to hear from in future chats? Don't be shy. Let's, Elizabeth.
Sorry.
Why don't you? Are you?
Yes.
Yeah. Elizabeth is clarifying that she works for the Center for Disease Control and seconded to WHO. Why don't you go ahead and speak, if you wouldn't mind, about the guidance from WHO on personal protective equipment, Elizabeth. Thank you.
Sure, certainly. And I've seen some of the questions in the chat and recognize that you all are facing a problem that the rest of the world is also facing, which is the lack of PPE, so the lack of appropriate personal protective equipment, especially face masks. And I know this can be very challenging, both in healthcare settings and outside of sort of healthcare facilities in the home or in other places where palliative care may be given. And it's something that countries around the world are trying to address, trying to increase the production of medical masks in particular. That is what the WHO recommends, are medical masks. If you are someone who is interacting closely with somebody who has infection with COVID-19, or for the patient themselves, or the person themselves, I should say, who has COVID-19, we recommend that they wear a mask if they're going out in public for any reason, like to a doctor's appointment, to the hospital, that they also wear a medical mask. Many people have asked us about the use of cloth masks, for example, and at this time, WHO does not recommend cloth masks. There are no good scientific studies showing that cloth masks actually definitively reduce the chance of either spreading from the person who's wearing the cloth mask, or spreading, if they're the person with COVID-19, or spreading or protecting the person who doesn't have COVID-19 from getting the virus. We're also concerned that the cloth mask can become very contaminated with respiratory secretions. If you're coughing or sneezing, all of the secretions can contaminate the cloth masks, and we're worried that then those cloth masks might be sitting around in the home. Other people could touch them. Other people who are responsible for disposing of them won't realize that they're contaminated, and they themselves might be exposed to COVID-19. So at this time, WHO is not recommending the use of cloth masks. Other ways but they are coming out. WHO will be coming out soon with some new recommendations on the extended use of masks, and also potentially the reuse of some masks or reprocessing of some masks. The other things that you can do to protect yourself from respiratory hygiene is ask people who have COVID-19 in particular to cough into their elbow, cough or sneeze into their elbow.
Pero no hay pantalla.
Whoever's speaking, can you please mute your microphone?
And also to practice very, very good hand hygiene. And then finally, to reduce the number of people who are getting close to the person who has COVID-19, so reduce the demand on masks. So maybe there's just one main caregiver who is taking care of a person with COVID-19 throughout the day, and then they can continue to use that mask throughout the day for up to maybe about 6 hours, maybe not the whole day, up to 6 hours while taking care of a patient, and just reducing the number of people who get close to the patient. Others can visit the patient or be in proximity, but should stay at least 6 feet away from whoever has COVID-19. Over.
Great. Thank you very much, Elizabeth.
Thank you. Can I just say something? This is Zippy.
Yes, Zippy. Go ahead.
I think the issue of masks. We've been told they are not really very necessary, but the thing is that everybody is watching the TV, everybody is watching news, everybody is seeing what's going on in hospitals, how the healthcare providers are protecting themselves. They are wearing masks. They are wearing, So it's very difficult to tell people not to wear masks when they already believe that this was going to maybe reduce the idea of reduce the fact that they might contract the disease. So I don't know how we're going to really, because, for example, our nurses, our doctors, all they're saying is, give us PPEs, give us masks, give us gloves, give us everything, and yet we don't have enough in the country as it is. We've run out of PPEs because the government has taken control of the PPEs and is distributing to government hospitals, and therefore they're not reaching really to the hospitals. So it's very confusing for everybody right now because we don't even have answers. Even when we talk about PPEs, is there a way that somehow somebody can, give us this money or direct us to where we can get some of the things that are very important, gloves and the rest?
Mm-hmm. Yeah. Thank you. Zippy, do we have any other questions about personal protective equipment? We can move on to other issues if there are none.
There's one from Hospice Africa Uganda, Stephen, asking about cloth gowns and masks. Yeah, I mean, I guess we've covered that. We've just talked about masks, but
well, the cloth gowns is a different issue. Elizabeth, can you comment on that?
Again, when you're close to, well, right now, WHO has no recommendations for or against cloth gowns. They are concerned in the same way with masks that there is no evidence that cloth gowns are going to protect somebody. That usually masks are impermeable, and gowns that we recommend for the healthcare setting are also impermeable, or those aprons are permeable. And so we have no evidence to say that cloth gowns would be protective in any way. The key, though, when tending to a patient with COVID-19 is to practice very, very good hand hygiene. So, because we think the hands are the place where the most contamination is going to occur, and it's the place where the hands are the ones that are sort of your ambassadors to the world, where not only are they most likely to be contaminated, but the hands are the ones that are most likely going to go out in the rest of the household, for example, or the healthcare facility, and touch and potentially contaminate the rest of the environment, or touch and potentially contaminate other people. So regardless of whether or not you're using a mask or a gown, hand hygiene would be extremely important. And as long as you have soap and water, you are able to do that. Over.
Okay, and what about the face shields, the clear plastic shields?
Yeah, so the clear plastic shields are recommended if often with a mask. They're used a lot in hospitals, and that's partly because healthcare workers in hospitals are going to be exposed to people with COVID-19 at a very high dose. These are people who are very sick, and the healthcare workers are working with them, for 8 to 12-hour shifts. And so they get exposed quite extensively to COVID-19. So this is the reason we have these higher level of suggestions of PPE for doctors and nurses. And we really want them to use it, is because of all of their exposure to the virus. We haven't, normally for home care, we suggest just a regular face mask, though I know they're hard to get. And if you are able to get a actual one of those face shields in the absence of a mask, it may very well provide some protection.
Thank you. That's great. Michelle Meering has a question.
Hi, can you hear me?
Yes.
I think in some really resourced, constrained settings, well, the question is whether a cloth mask is better than nothing. And I do know, obviously the studies have been done in good quality surgical masks. And what's happening now is many people are reusing surgical masks. They're becoming dirty and infected. And the view in Africa is that at least you can wash a cloth mask. So people are being told, the evidence isn't being developed fast enough to deal with resource-constrained settings. If we can have 2 cloth masks, we can wash and iron one, at least we can have a fresh cloth mask every day. And I see there are even some ingenious suggestions on how to put a tissue filter in between that can be removed on a daily basis to convert a cloth mask into something slightly more protective. I'm busy supporting a colleague in Malawi at the moment who has nothing, doesn't even have running water in his hospital. There's no soap, so they can't do as much of the hand hygiene stuff as they need to. So people are needing to come up with PPEs that are not necessarily going to be evidence-based because, they don't have the equipment to do elsewise.
So this is Elizabeth again, and I completely sympathize. I've worked in many resource-limited settings. The best we can do right now, though, is provide recommendations based on the science, and we realize that people are going to have to or want to do something that is beyond the current science that we know. And so at this point, as more of a representing the sort of the science of it, this is why WHO and has not come out in favor of using cloth masks, because we don't have evidence that cloth masks are effective, and because there is some concern, as you were mentioning, like with the washing of the masks, for example, that if somebody else is washing the mask, then that person may be contaminated by touching a mask that's been used all day and is potentially infected with the virus. And there is definitely a concern about that. And so if someone were to take that approach of using a cloth mask, then we would suggest that there be very careful disposal or tending to that particular piece of cloth, because we think that particular piece of cloth will be quite infected with the virus. And so that's something to take into consideration. Over.
Thank you. Okay. If you want, I'd suggest you go ahead and use the raise hand function to indicate that you want to ask a question. We have a question from Hospice Africa, Uganda. Hospice Africa, Uganda, are you there?
Yes, I'm here.
Thank you. Yeah, you in the chat box, you're talking about home quarantine. Can you go ahead and raise your question?
Thank you, everyone. My question is about patients that we are taking care of in the home. Many of our patients are visited at home on a routine basis. But if we have, in a situation like this one, where many of the people that may have acquired COVID are at home, either on quarantine or in isolation, before they actually access a hospital, before they are actually diagnosed, there's a risk that they have COVID. And I've basically been quite skeptical about doing these home visits. I just wanted to hear from others the PPE that is required in such a setting. To what extent should one go? I'm listening in and trying to learn some more about the PPE in such a case.
Thanks very much. Any comments?
Can I make a comment? I don't have the hand raised thing, sorry.
It's okay.
I don't have the question to answer and say that we have the PPs available. But one of the things we have been discussing with our hospices is that they dispense drugs for at least 6 weeks for the patients, so that even if they're not able to go and visit the patient has got drugs with them, and they can give them advice over the phone, because almost everybody has a phone. So if it's very difficult to get to the homes, it would have been good to get to the homes, but we should maintain contact over the phone. WhatsApp is very common in Africa. Everybody almost has WhatsApp, and also ensure that the patients have got enough medication for the 1 month to 6 weeks. But also give them information. We are trying to work on pamphlets, give them the correct information about the virus and how they can protect themselves and their caregivers as well. So we still need to work through a lot of these things to be able to get the information, the right information, and to maintain the contact with the patients at home.
Thank you. Yeah.
Hi, it's Julia here from ICPCN.
Yes.
Just to add to that, I know a lot of palliative home care services are doing that. So they are making sure all the patients have what they need, and then doing follow-up by phone, and only doing face-to-face visits if really needed. It's not ideal, but it is one way of making sure that you keep in touch with the patients, that you're not putting them at risk by taking something into their homes. And the other issue, and Moira might, and the team from Hospice Africa Uganda might be able to say more on this, but in some places like in Uganda, they've stopped all public transport. So many people actually can't get out and do home visits if they're using public transport to do that, or even get into the hospitals to work.
Hi, Stephen. This is Joan. I just want to say that one of the challenges that we have here in Africa is that the hospice teams do not only do home care, they often take essentials like food parcels. And this has been a big challenge to us as a children's hospice here in South Africa. But we feel that, I mean, we've done a lot of sending out of food parcels before we went into lockdown, but our carers are still going to go out and see their patients. We're going to give them PPE, and we're going to still continue to give essential food because we can't bear to see our children going hungry.
Yeah, I think there's still, Elizabeth, I think there's still some confusion about whether, we know that WHO is not recommending the use of cloth masks, but if you have nothing else, I know some of the guidance in WHO materials has said, bandanas or, using some cloth and then properly cleansing that, at least I think on a daily basis. Do you have any, do you have any guidance on that, or is that something you don't feel based on the evidence we can even say anything about?
So WHO at this time has no guidance or recommendations for cloth masks. CDC does have some recommendations for using cloth and making sure they're disposed of correctly so that no one else is contaminated by them. And it's really when you have nothing else. So those are the differences between the two major organizations. Over.
Got it. Thank you. We have a question from Edna Hamza in Malaysia about the experience people are having. Most of the patients in the sort of public reporting appear to be dying in hospitals, but what do we know about dying in the community and the experience of caring for them? And Libby Salno, I'd like to ask if you might address that question first, if you don't mind. Unmute you.
So, talking about people dying at home,
yeah.
So we've had a few very rapid discharges, and I think what the key thing we're learning from our experience in the UK is that it has to be very rapid, because when people are either taken off oxygen or taken off non-invasive ventilation masks, the windows are short, and that people are needing quite high doses of opiates to support their breathlessness. So we've been looking at things like, syringe drivers and oxygen. That's just not enough time to get that ready. So if people are being discharged from hospital, they can sometimes come home with injectables for the carers to administer, or with a syringe driver set up. But for the patients who we are anticipating really over this weekend and into the next week, we're anticipating large numbers of people who will not be going to hospital in the first place, and they will be simply cared for at home. We are writing guidelines for non-subcut immediate release, either transdermal, buccal use of medications, particularly opiates and benzodiazepines, to allow people with rapidly progressive hypoxia to be managed in the community. And I know many other centres around the world have already been doing kind of carer administration of medication, and obviously in the UK it's been normally led by community healthcare professionals, and we've had to rapidly change that because we acknowledge we won't be able to get there, both because of the rapidity of people's symptoms changing, but also the numbers of people dying and the sickness rates in the staff, and just the time of not being able to get out there. So we are now trying to get everyone coming home from hospital with either transdermal or buccal routes of opioids and benzodiazepines. And we've also been changing the chief coroner has changed the law with the emergency bill that's come through, because currently we were having to see patients in the past 14 days before they died to then allow you to issue a death certificate. But home, and so I think one of the key things that's been helpful this week is looking at legislation to allow people who may have doctors who've not seen the person in their illness before they've died to then issue a certificate, because we're anticipating really large numbers, and that being a real public health challenge as well. So it's kind of, we've looked at changing our symptom control guidance. We've rushed through carer administration protocols that in the red tape in the NHS would have taken. We've been working on it already for a few years. They're just rushed through. We're just doing it now. So doing that through Zoom, or 15-minute, very short 15-minute interventions. We've been told to limit our home care to 15 minutes, which you can do almost nothing with, but that's what we've been told to do. So trying to get those symptom control guidelines, and then looking at what legislation we need to support to allow people to then have a death certificate so they can bury their loved ones.
Which symptom control guidelines are you utilizing?
So we have written our own ones. I'm really happy to share one. These are pan-London ones that have been pushed through, so I can share them with you and Claire. They're hosted on various different websites in the UK, and it kind of talks through ideal if you've got symptom control. You've got options for subcut administration, say in hospital or hospice with healthcare providers, and then if you need a syringe driver, and then if you don't have any of those, what buccal or other preparations. And actually we're drawing for a lot of work around the world where syringe drivers are not possible. So we've been looking at higher concentrated buccal oral solution that then is absorbed across. So we're actually learning from partners all around the world from that.
When it's available at all, which is
yeah, completely. And actually, if you've got 4 hours exactly, that's the kind of time frame often people are looking at. So we've also developed some guidance that we can give people who are caring for people at home alone, just a 2-page guidance, what is normal and death, how you support people. So I'm happy to share all those resources. Maybe I'll send them over to you and Claire later, and you can look through what you would want to upload.
Great. Thank you very much. Joan Marston has made a comment about the use of cloth in South Africa, apparently. Joan, are you there? You want to comment on this quickly? The 2 hours.
Yes, I can just say what we've done with our hospice staff is, first of all, we've trained them how to use the masks correctly, how to handle them. then how to dispose of them into a sealed bag. And when those are put in the washing machine, we use gloves for those. And the staff are told only to wear the mask for 2 hours. We've had wonderful volunteers who've made a mountain of masks that can be used. And that's the best we can do, because we really cannot get the surgical masks for use in the community.
Thank you, Joan. I've had a number of comments from Dr. Nizam in Bangladesh. Nizam, do you want to come in with your question or comment? Are you still with us, Nizam?
Yeah. Yeah.
There you go. Okay.
Can you hear me?
Go ahead. We can hear you.
Yeah, thank you very much. I was wondering that when someone says that we don't have even face masks and other PPEs for doctors and nurses at all, this is creating more confusion rather than any support. In the street, you will see lots of people, journalists, police officers are wearing PPE, and we have 4 doctors infected with the virus out of 48, and 3 or 4 nurses. Now, so I think that PPE is creating more confusion than really doing any good to us in Bangladesh. And secondly, I was actually wondering when you said that cloth masks cannot be used even after washing with soap. Now, so I think that you're talking more for the world where you have lots of masks and other PPEs, etc., etc. So I was wondering about that. I had a question that how long a dead body the virus can survive in a dead body, because in Bangladesh, quite a few dead bodies are still lying in houses where nobody is dare to touch the body. So I had a question for Libby, actually. What about the dead
Can
body?
you answer that question, Libby? Thank you, Nizam.
Does that to me, did you say?
Yes.
Yeah. So we're trying, I think in Italy, I don't know if anyone's here with some experience of that, but I know some people were having to, because of isolation and people not coming to collect bodies, that there were reports of people having to spend a long time with bodies in the home. I mean, I don't know, I don't have any kind of specific knowledge about how long, and it's about obviously the temperature and trying to keep things as cool as possible. But I think there's real public health challenges with collecting and disposal of bodies. And certainly here, funeral directors are very panicky. They're double bagging, body bagging people, and not letting relatives see them after death, etc. So I think there's a lot of fear and misunderstanding about transmission of infectious diseases. But also some of that is very real, and obviously there's body fluids. So I think it's about trying to support the disposal services as rapidly as possible, but other people might be able to comment more, and particularly in a hot setting.
Hi, this is Elizabeth Bancroft again, and WHO just published this week a pretty comprehensive document on dead body management of people with COVID-19.
Great.
COVID-19, sorry for the dogs barking in the background, they're not mine. COVID-19, I think a lot of people are treating COVID-19 like it's Ebola, you know, the double bagging, the being afraid to touch a dead body with COVID-19. And we think that the people who are tending to the bodies can be, if they wear gloves or use very good hand hygiene after they've tended to the bodies, all they need to do is wrap the body in a cloth, trying to keep in as much of the bodily fluids as possible, and to transport the body. But there's no special transport cars needed. This is not a Ebola situation. People can certainly see the body after death. That is perfectly acceptable as long as the family or loved ones don't touch the body. So we have, or WHO has very comprehensive guidelines that have just been put up, and I highly recommend people to go to the WHO website to look for them, and we're hoping it will calm some fears out there. Over.
Great, thank you very much, Elizabeth. That's appreciated. Michelle Mearing, you have your hand up to come in.
Speak back to the opioid issue. And I mean, even for standard palliative care in many African countries, we can't use buccal and subcut and transdermal routes. We just don't have access to that. So I'm just wondering what my resource constrained settings are thinking in terms of, are we going to be giving opioids rectally? Are we going to be using, I know people have been talking about using long-acting MST rectally. Are we going to be inserting nasogastric tubes to give oral morphine? How are we going to get morphine into very dyspneic patients without any of the routes that we've been talking about?
Well, we certainly have had some experience in using rectal morphine if it's done properly with gel caps and proper insertion. It's basically so availability should be roughly equivalent to oral. But any other comments from others about means of administration of morphine when?
So we've been looking at higher concentration of oral morphine solution used buccally, inserted into a couple of mils and rubbed in, and alternating the side for that, because similarly, I think, you can use injectable morphine as well if that's available, or high concentration solution for oral use. And the same with midazolam or any other sedation, any other benzodiazepine that can be inserted buccally and then rubbed. I mean, it depends obviously how feasible that is if someone's really dyspneic or has no saliva and has a very, there's lots of shortage issues with that, but that's something we're looking at as well. And then rectal measures as well. I know there's been some thought looking at intranasal morphine. Intranasal morphine doesn't have any absorption across the membranes, but apparently intranasal diamorphine does, and the same with midazolam. But we can't get diamorphine anymore here either, so it's all a bit academic. And I don't know how possible in a very dyspneic patient it would be to actually inhale. You need quite a passive measure to give these medications. So I think buccally and rectally are options.
Yeah.
May I?
Raj Gopal, please continue.
Yeah, and this issue of administration when the patient cannot swallow is looming large, and we don't have morphine suppositories in most developing countries. So we actually manage, not only in this setting, even in other settings, by using the tablets lubricated well and pushed up the rectum, unfortunately. Unlike buprenorphine or diamorphine, because of the difference in lipid solubility, buccal administration for morphine is very ineffective. The absorption will be very, very poor. Therefore, the choice other than swallowing the tablet or parenteral injection for most of us is limited to rectal administration of ordinary tablets.
Good. Thank you very much, Raj. Claire has shared, by the way, WHO's home care guidelines in the chat box for the questions regarding caring for patients at home. Hospice Africa Uganda, you had a question regarding the dying process for people who are dying from COVID. What things we should expect and how can we best manage? Would anyone like to take that question?
This is Zippy. I don't have the answer to that question, but what I see is that if patients who, palliative care patients, if they happen to end up in a hospital and they're dying, there will not be a priority at all. I mean, that's where the ethical issues come in. There will not be a priority for ventilators, for good care. They will probably have a very miserable death. And the ones who are dying at home and have nobody visiting them might also go through also a lot of suffering and before they die. So I don't know, maybe these guidelines that we are talking about, that we are developing already, we need to really focus on practical issues. We can't just imagine that a palliative care patient is going to end up in a hospital on a ventilator or whatever, they will be the least priority in terms of access to probably treatment for COVID-19. So I think it's very difficult to answer that question, how do we support the ones who are dying? Like we said earlier on, I think talking to them is very important, talking to their family members, maintaining that contact is very important. The psychological part of it, the spiritual care, trying to get a spiritual person to even call them and talk to them is very important. This is something that is now out of our control, and it's out of control in the whole world. And so we have to come up with practical things as everything emerges. We really have to think very quickly and be able to support our patients and their families and support our caregivers, because from morning to evening, I get emails, phone calls, WhatsApp messages, and everybody's just talking about how do we do it? How do we protect ourselves? How do we protect our patients? So we need to come up with things that are very practical, even guidelines on supporting a patient who's dying. I know we've done a lot of end of life issues, and this is usually because you have been prepared for somebody who has been sick for a long time and all those. But this is somebody who's stable with cancer, but now all of a sudden gets COVID, and things change completely for the family. We have our first death in Kenya, a 56-year-old man who had diabetes, very okay, had no issues with diabetes, well controlled, but has died of COVID-19 just yesterday, or is it this morning? I can't remember. So we need to really think of being very practical. Whatever you're going to produce has to be practical. Like Dr. Raja said, rectal, use of oral morphine, although some of us don't have the tablets. I think sometimes you just think when it's happening at that time, what can I do to help this person?
Can I just come in as well? I think the other thing for us all is forward planning is so important at the moment. For me especially, if they're not going to ventilate me in hospital, I'd rather stay at home. But I'm lucky that I've got access to IV antiemetics, I've got access to fentanyl buccal, I've got patches, but even in a lower income country, I think we need to think ahead for patients with life-limiting illnesses and think, what can we do to anticipate what might come next? Because then we can start to put things in place to help people preemptively.
Wise words, Lucy. Thank you. By the way, I want to mention a number of people, Chelsea, Petal, and a few others have asked where the resources are. And Claire put this up, I think, a little earlier in the chat, but it's on our website, the WHPCA.org/COVID-19. You can go directly there, or just go to the website and look at the button at the top that says COVID-19.
Stephen, just to add to that, there are quite a few resources around on different sites. So the APHN have got resources, ICPCN have got resources, EAPC. Some of them are the same.
Many cross-linking to each other, I think, so you can find a lot of them that way.
I know APCA are putting some up, but I haven't seen them yet.
Right. And then some of the things that we've discussed on this call, we'll certainly be providing through our links, and others will do the same. Yeah. So we have, by the way, we're not going to be able to respond to all the questions in the chat, but we'll do our best to, we will be able to download that. This webinar is being recorded, so we'll also have that on our website, along with the list of chat questions. Mara, you had a question for a comment Libby made about 4-hourly sub-Q. Is it sub-Q for opioids? Mara, are you there?
Hi, thanks, Stephen. And thanks, everyone. Really interesting discussions. I think I was just agreeing very much with all of our colleagues that low and middle income settings are very tough. But one thing we have found is when you can't find any other form of administration, there are insulin needles. So it's just to let people be aware that that can be a very relatively, still difficult to access, but relatively easier to access than other forms of parenteral like syringe drivers and the like, and they can work well for single subcut injections, and you can give that 4-hourly. I completely take on board that this is difficult, but can I also encourage us to work with our hospitals, because in the hospital setting where many of these patients will be, not all of them by any stretch, they don't know how to do this. So can we also work with them to make sure that we get good symptom control in the hospital setting, as of course we are trying to do in the home setting too. Thank you.
Thank you, Maura. Hospice Africa Uganda has a question around how airborne COVID-19 is. Apparently, we've got some conflict of information. Elizabeth, perhaps you can answer that for us.
Sure. So right now, WHO feels that the primary mode of transmission is droplet and contact, having close contact with a patient or the surroundings of a patient. Environmental contamination, where someone touches the environment that has been contaminated with the virus and then puts their dirty hand now up to their mouth or nose. There is very little evidence that there is airborne transmission of the virus. It's really considered droplet transmission. Therefore, if you remain a good 6 feet away from somebody who has COVID, you should be okay and protected from them, and that's something to think about for the people who are making visits, is that if they can still make a visit and still have that face-to-face contact with a patient, but maybe not the actual hand, or skin-to-skin contact with a patient. As long as you remain 6 feet away and practice hand hygiene on your way out, you should be protected from COVID, because we do believe that it is droplet. It is spread by droplets, and the droplets fall from the mouth and the nose within about a 3 feet distance and fall very quickly to the ground. Over.
Thank you. That's clear. Julie Downing, you are mentioning the need for guidelines for low and middle income countries. Do you want to comment on that?
Yes, I think we're all aware that we desperately need some guidelines for low middle income countries, where many of the issues are different, and we've already heard about people living in the slums, a lack of access to medications, a lack of access to PPE, etc. So there is a plan in place with several organisations, IAHPC, ICPCN, WHPCA, PALCHASE, and hopefully others, to put together some guidelines on different areas for COVID. One is on children, obviously, but also one is specific for low middle income countries. So we have a call later today, and I know we'll be getting in touch with some of you here to help with those. But we're aware that we need them urgently. We're also aware that we don't want to reinvent the wheel. So looking at what is already being developed and what is already out there. You might want to add something on that, Stephen.
No, I think that there are unique challenges. There definitely are differences between high income country systems and low and middle income countries. And I think there are differences between low income, middle and lower middle and upper middle that we need to pay attention to as well. We have had a few questions here about availability of medicines, and I think we haven't really dug into that too much. We know that a large proportion of the of low and middle income countries are not able to access opioids effectively. Could we have some thoughts about how we could improve access to medicines for low and middle income countries?
Zippy again.
UNODC that was supposed to be on the call. I don't know
before they answer, can I just say that the price of morphine powder is very high right now. It's about $4,000 per kilo of morphine. It's really, really very expensive. Is there a way that we can ask them to reduce the cost of morphine powder?
That's for McFarland Smith, in the UK?
UK, Hungary, everybody. It's just coming in very expensively right now.
Wow. Yeah, good. Well, great point. We can try to work on that. Is Beth Matfield on the call from you?
Yes, I am.
Oh, Beth. Yeah.
I am here. Thank you. And hello to everyone. I'm sorry that I wasn't on the call directly in the beginning. I think that you're raising a very complicated question, and in today's time, we would like to have a simple answer. We would like to be able to say, here's the magic solution so that we can really help countries that are suffering with the pandemic. but the actual answer is often very complicated. For some countries, it has to do with trade agreements that they have and needing to perhaps expand their ability to be competitive within the market. For other countries, as Zippy has just alluded to, they're really going to be impacted by the increased demand at the moment for all health care products, all medicines, all devices, everything I think will be feeling that increased demand and that increased attention, and that will result in price increases. So one of the things that I've been really talking about and trying to find a way to be helpful is to really think about, is there a way to have I'm not sure how to say it the right way, but a fast track for procurement of some of these necessary medicines. I think in this particular time, it may be something that we could pursue, but I don't think it will be necessarily easy. There are countries that have already some mechanisms built into their national regulations that would allow them during crisis times to access medicines in a different way. So I encourage people to look and see in their own home countries if that's an option as well for procuring medicines during this difficult time. I wish that I had a better answer, but I'm not sure that I can help quickly in a short period of time, just in response to this pandemic.
Yes, this is Zippy again. I just want to say thank you, but I think if you look at what's happening across the whole world, people are now realizing this is a big problem, and people are giving in. So these companies that are selling medicine should also do their part on humanitarian grounds, because everybody is giving things now. Because even right now, we are taking care of patients and not charging them, because there's no way you can charge a patient at this point of time. There are no salaries, people are not working. We can talk to this, but we can write to them and tell them this is a big problem. They have to be part of the solution. They can't just be thinking of their profit margins. There's no profit going on in everything right now, except those who are selling masks, maybe. But we need to really, we need to use an approach of please be part of this problem, solve this problem together with us.
Yeah,
100% agree, Zippy.
We've actually had some conversation with WHO about creating a kind of group purchasing mechanism for essential palliative care medicines, including opioids. The problem has obviously been, the degree of control and countries' own systems for controlling the access to opioids. So that hasn't panned out, but it's something that's been explored. Maybe we need to look at it again. Catherine Pettis, can I ask you to come in and as one of our experts on drug policy to make any recommendations or comments about this?
Well,
problem?
Thanks, Stephen, and thanks everyone for being on the call. The only thing I would add to what Beth just said from UNODC is that the International Narcotics Control Board about a week ago issued a circular to all governments reminding them, in case they didn't know, which most don't, that they need to have controlled medicines available for patient care in this pandemic, and that the ordinary business as usual rules, INCB rules, have been developed. And I don't want to say that they don't apply, but there are emergency exceptions for opioids, and we've circulated that press release. I haven't seen the circular, but I've seen the press release, and a circular to that same effect was sent around. I can send it to the chat if people want to see it. So the thing would be that this isn't just another document, it's something to remind your health ministry and your hospital administration about, that this is coming from the UN level, that they need to have medicines available. But then you've got all the supply chain issues that Beth just mentioned.
And also, Stephen, if you don't mind me adding, that in addition to your work that you've been doing with WHO, INCB and UNODC and WHO have also been working on at the regional level for quite a while now to try and get regional type procurements. So this might be more of a moment where if we can't do it at the global level, perhaps at the regional level, particularly in Africa, that might be more possible.
Mm-hmm. Excellent. Good news. That's good to hear.
Stephen, Jim Cleary here. Sorry for joining late.
Okay.
One of the things that Nathan Cherney shared something from Israel yesterday about symptom control in this pandemic. One of the things that he's suggesting is the low dose fentanyl patch. And as much, and particularly this becomes a staffing issue and protecting staff, because we can actually minimize contact with infected patients if we're not having to give medicines or run IVs. And I'd not thought of that perspective before, but that was an interesting perspective to hear from Nathan. As I hear Zippy saying companies ought to be stepping forward, is this somewhere where the people who make the patches, I still have ethical concerns about high dose in elderly people getting their first fentanyl patches and things, but in the context, I think it makes a lot of sense.
Okay, thank you, Jim. We're down to about 4 minutes left for the chat. I did want to have us touch even briefly on the need for psychosocial and spiritual support for families and people dying from COVID. There is, Lucy has shared with us some bereavement support guidelines from Cruise in the UK. And there's a link in the chat to that. Any questions or comments or resources about psychosocial spiritual care for self-care? Nothing? I think there's been a lot of discussion about
there's no question.
Go ahead, Zippy.
I was just saying that there are quite a number of links that have been shared during this call.
Mm-hmm.
And so we could not keep up with the links and the call and discussions. Can these links be later on sent to us so that we can also share with others?
We're gonna post a audio and video record of this call along with the chat content. We'll put 3 documents up in the COVID-19 section. There's a section now we're creating just for webinars.
Thanks.
We're really down to a short period of time.
Stephen, I'm going to raise Jim Cleary again. I'm going to raise another issue. And as much as seeing people is actually good, I am actually very, very worried about the bandwidth of all these people doing all these video conferences. And I'd hate for the internet to crash. And I think we may actually have to be protective. I like the fact that Catherine's put a picture in there. I think that may actually be the thing we need to be a little more creative with, because, and I'm being real, the internet crashes, we're in big trouble.
Well, we've noticed some slowdowns from time to time, but I don't know that anyone is.
That may be a bigger issue in low resource countries than it is in the high income countries. Certainly. So I think we've got to be cautious all the way around.
The body management policy link is also in the chat, Elizabeth. And we've had some questions about nursing home, managing patients in nursing homes. Well, we're really down to 1 minute. Does anyone? I'm actually pleasantly surprised at how well this has gone, and I think we were really concerned that there was going to be a lot of chaos and background noise and problems with too many people kind of trying to talk at the same time. And it seems to have gone, from my view, pretty well. I hope you agree. We are going to be continuing to have these webinar chats on Fridays, Jim, regardless of as long as the internet is working. I think it's quite important.
I don't have a problem with the chatting. I'm just worried about the video bandwidth.
Yeah.
Talking is quite good. I think that just as we transmit video, that's a lot of bandwidth.
Well, most people have their cameras off on this call. It's a relatively small number who have them on. And the way Zoom works, interestingly, we don't, everyone has their own channel. So it's, it isn't it doesn't, if you have a bunch of people all on video, it actually doesn't affect the quality of the call, except for that one person in their, their internet connection and how strong it is. In any event, it's 10 here in Washington, D.C. and 2 p.m., I think, in London. And we appreciate everyone taking the time to join us today. We are going to post later today all those documents that we talked about on the web. We are going to be putting together some additional guidance, relatively short pieces of 3-4 page kind of guidance on specific topics that we're going to, we being the International Association for Hospice Palliative Care, International Children's, and the other partners that are part of this effort. So we'll be doing some somewhat structured sessions in the coming weeks, but you can, and we may have to change the link that we're using for this one. So keep an eye out for notification about the upcoming Friday webinars. And respecting everyone's time, I'm going to go ahead and sign us off now. And again, I want to thank particularly the experts that joined us on this call, Julia, Lucy, Elizabeth, Beth, and others, and Roger Paul and others. And I hope everyone has a great weekend. Thank you all for joining us.
Thanks, Stephen.
See you
Thanks,
again.
Stephen.
Welcome.
Bye.
Thank you. Bye.
Bye-bye.
Thank you so much.
Thank you so much. Bye-bye.
Bye.
Bye.